Hi, my name is Steve Hayes, and this is one of a series of discussions that we're having with experts on ACT and contextual behavioral science and third wave interventions and so on, RFT, that whole collection of issues. Our expert today is Jonathan Brecker, who's at the Hutchinson Cancer Center at the University of Washington, and has been doing some very interesting work on trying to take some of these methods and looking at them from a public health perspective, which I think will be the focus of our discussion here today, particularly with smoking, but I imagine we'll get into some other things as well. What you're seeing here is part of a class, and you'll meet the members of the class in a little bit as we get to questions and answers, and they'll introduce themselves when they have an opportunity to ask their questions. So with that as a brief introduction, let me just turn the microphone over to Jonathan and just to proceed ahead as you with, Jonathan. Well, thank you very much for playing with us today, and welcome.
Oh, well, thank you so much, Steve. It's an honor. It's a pleasure for me to be here, and today I'm going to be talking about the public health approach to acceptance and commitment therapy. And we go ahead and I'll call up my PowerPoint here. So I'm calling this about reaching out. You know, as clinical psychologists, we're well trained in how to help people who come to see us in our offices. In whether we're doing individual therapy or whether we're doing group therapy, that's kind of the traditional, that's the main way we normally engage in working with our clients and helping them alleviate their suffering. And there's another side, there's another way in which I think we can engage with our clients, and that's by taking a public health view. And so I'm going to be sharing that with you today and kind of giving you an overview of what that approach means, and then I'll give an example of how I've been applying it in my work with my colleagues at the Fred Hutchinson Cancer Research Center at the University of Washington, in which we've been applying this to acceptance and commitment therapy. So let's get started by just beginning to look at cognitive behavior therapies broadly construed. And we put ACT under the umbrella, the larger umbrella of cognitive behavior therapies, and just look at how effective they have been and the ways in which they have been delivered and what implications our delivery methods have had for our clients and for serving the community. Now, as we're all aware, cognitive behavior therapies are effective. They work. They work for a variety of problems, and many variations of cognitive behavior therapy have been used, for example, for depression. We know, for example, from Sonnen Dimijan's work on the Neil Jacobson study of behavioral activation, that we know that behavioral activation is effective for depression. We know that cognitive therapy, whether we're using the Beck model or the Ellis rational emotive behavior therapy model, is effective for depression, and variations of that are as well. And then we are having more and more data coming out showing that acceptance and commitment therapy is effective. In fact, the Division 12 has added it as showing it as having at least modest effectiveness for depression. We know the gold standard, the Barlow panic control treatment, is helpful for people suffering with panic disorder. And then we know in the area of smoking cessation that a number of different cognitive behavioral skills training techniques, modalities, models are effective for smoking cessation. And this is very encouraging. This is good news. And we continue to refine, develop, improve upon the cognitive behavior therapies so that we can be more effective for changing these problems. And so that's really a positive thing, and it's something that's the foundation on which our work has been built. And the way in which cognitive behavior therapies are now delivered, as I alluded to in the beginning, was in a face-to-face context. That's usually how we work. That's how we were trained. If that's how you're being trained now in your graduate training, and that's typically individual and group therapy. The settings in which we provide this are usually a private practice setting or an inpatient or outpatient hospital setting, primary care, our university clinics, community-based mental health centers, et cetera, et cetera. So there are many different settings, and they're usually an office or medical-based setting. And there's a problem with that. I think there's a really, really important problem with that. As helpful as our therapies are now, and as helpful they're going to be in the future, there is a problem with the way we are delivering it now. And the problem is we're not reaching the people who need this help. For example, in the case of depression, only about 10% to 30% of depressed people receive any kind of psychotherapy. And when they do come in, only 4% actually attend 4 or more sessions. That's actually of all depressed people attend 4 or more sessions of therapy. That's extremely low. In the case of smoking cessation, only 1% of smokers try quitting using cognitive behavior therapy or any other kind of counseling. And the issue this raises, if you just look across all the major psychological disorders, on average, only about 11% of people with a psychological problem actually seek counseling. So we're not reaching them. And there are a number of reasons why, but that's the main point, is that we're not reaching them. And a way to think about why that is so important is to think about impact. So from a public health point of view, there are 3 parameters that are really critical. One is, what is the reach of your intervention? That is reaching the people who need it, and I'll tell you more about that in a moment. And then how effective or efficacious is it? Depending on how you conceptualize those, you can use either word. And that together, reach and effectiveness, give us impact. So impact is a very important metric in public health research because it gives you an overall metric of what contribution your intervention is providing. And I'll give you an example for depression, the CBT. If we take the parameter 10% reach, and let's say half of the people we provide treatment to reach a clinical improvement level, and you multiply that score by 100 just to come up with a simple metric, you get a 5 impact score. And that's a score that can go from 0 to 100. We're getting 5. Similar for smoking cessation, as I mentioned in the earlier slide, 1% of people are actually getting counseling for smoking cessation. And in the area of smoking cessation, you get much lower quit rates than you do for depression. So the average is about 20%. And now you're getting an even tinier impact score for the case of smoking cessation. Again, this is 0 to 100 scale. So in a very straightforward way, we're seeing that we are simply not making very much impact with the interventions that we're providing. And why is this happening? Well, I think there are 5 reasons why. One is it's expensive. It's expensive to train us to provide the therapy and then to supervise individuals in providing the therapy. It's expensive to deliver for the clients to be able to afford treatment. Now, the new health insurance law that was signed into effect, it's going to help somewhat with providing coverage for people to get psychotherapy, but it's really still going to be extremely limited. And so the poor are going to be having severe barriers to being able to afford treatment. Cost is enormous. And in fact, there's a whole area of research in public health that just focuses on cost effectiveness. I have a colleague at the Hutchinson Center who's an economist, and his whole line of research is devoted to calculating the cost effectiveness of various interventions. And so we can chat about that if you're interested. But cost is enormous. That is a huge, huge challenge, and almost should be all capitalized because that's such a big problem. Time is another issue. Therapy, typical model, about 12 sessions in a 50-minute session, and then you've got to get to the clinic, and then you've got to get back. I did a TV interview, was in Reno in November, where we talked about the issue. Gave an example of a gentleman who would have to leave work to go and get help to quit smoking, and that it means he'd have to take unpaid time to go and get help to quit smoking, in addition to the time it takes to get a session in. So time is a barrier. And then there are enormous demographic differences. Men, minorities, less educated individuals, people under 30, and people over 60 are the least likely demographic groups to have any kind of psychotherapy. And this is not just limited to CBTs, it's all psychotherapies, and CBTs are an important example of that. People who live in remote areas, people who live in rural areas, people who live in many suburban areas have difficulty being able to get access to care. The CBTs were developed at major research institutions. And so if someone is living in the suburbs, that's maybe an hour and a half from a major city, it's very impractical for someone to go into a university clinic or to see a practitioner who was trained at a major university who's in practice near the city to be able to get help. So the people who suffer the most are the people in rural and suburban areas. Now, I mentioned there were 5 barriers, and the 5th one is one that people tend to forget about, and I think it's extremely important. And the 5th barrier is stigma. There is still in our society a tremendous stigma about seeking any kind of mental health care. People have a lot of ideas, some of them are misconceptions about what happens in therapy, and then there is a real stigma that they experience going into therapy from family members, from people who don't know them very well, that the sense of being judged for seeking psychotherapy and going through psychotherapy. And that's one I think that isn't talked about enough. It's a huge problem. In June of last year, the APA Monitor magazine devoted several articles to the issue of stigma, in particular helping people who are veterans or active duty military to seek help and seek help early. Because, as you can imagine, in the military, there's an enormous stigma about going in to get help, and being perceived as weak. And here you are, you're trained as a soldier, you have to keep up this facade of being very strong when if you're suffering, you're experiencing depression, symptoms of PTSD, substance abuse. It can be very difficult to go and get care, and there may be real organizational barriers to that in terms of how your commanding officer may respond to it. So the military is stepping up, and they're trying to address this problem, and really to be congratulated for taking some initial steps in that direction. So I've told you so far about how effective our treatments have been and this serious problem of reach and the reasons for this reach. And to me, this raises an important scientific need that can be addressed, can be examined carefully. And that is the need for a testable and useful approach for overcoming the barriers to increasing the reach of cognitive behavior therapies. And one approach, which I think is be very useful, is the public health approach to cognitive behavior therapies. So I want to tell you a little bit about what I mean by the public health approach, and I'm going to show you an example of how I've been applying it with my colleagues. The public health approach takes a very, very different focus than what we are used to in our traditional clinical psychology training, behavior analytic training. And that is a focus on the population. Instead of focusing on the individual, we are focusing on the population. We're saying, what impact does an intervention have at the population level? And we focus a lot on reach, as I've mentioned before, that is, people who are left out by the clinical approaches are often included and focused on in the public health approach. So a lot of public health research, intervention research, focuses on the poor and focuses on minorities. There's an enormous area of research funded by the National Institutes of Health on health disparities. In fact, just yesterday, Julie Rowland, the head of the Cancer Survivorship Office at the National Cancer Institute, was out at the Hutchinson Center giving a talk on cancer survivorship. And a huge area of research now is on cancer survivorship disparities and looking at how the quality of life needs and some of the mental health needs differ so much in different minority groups. For example, African Americans tend to fare worse in looking 5-10 years out after their cancer diagnosis in terms of quality of life, in terms of survival, in terms of obesity, in terms of recurrence of cancer. And so in the public health realm, we focus a lot on those who are in greatest need. And reach in a technical sense simply means that you've defined a population of people. Let's say it's all smokers in the state of Nevada, and you want to learn how much your intervention can reach that population, or all smokers who in the state of Nevada who want to quit. So you're defining your study population and you're seeing to what extent am I reaching that definition of people. Reach has been applied often, as I mentioned before, toward those in greatest need, those who tend to be left out. And then, as I mentioned earlier, cost of delivering intervention in a cost-effective way. So you're looking at what does it cost to deliver and what is the yield on the investment. Is a huge focus from a public health point of view. Tends to not be so much of a focus on the clinical point of view that we have usually taken in the world of clinical psychology. How has this been applied? Well, the upcoming issue of BRAT is focusing on dissemination. So dissemination is one piece of the public health approach, and that is how much can you be able to penetrate various healthcare delivery systems and be able to penetrate the community to be able to provide these different cognitive behavior therapies. Now, in this particular issue that Roz Safran guest edited, a lot of the focus was on the internet, which is certainly one modality, one way in which you can disseminate. There are many ways, and the internet is one of them. Now, in one of the readings I had you take a look at, there was this article that was published by Kessler, David Kessler, in The Lancet, where they were providing what was essentially an internet-based intervention. In the internet-based intervention for depression. And there's some interesting qualities of the study that I think are worth noting. And one of the qualities of the study is that they provided a text, what's essentially to me looked like more of a kind of a text messaging version where you have a trained psychologist providing the depression treatment. It's a fairly standard cognitive behavioral therapy with traditional cognitive restructuring. And so they are texting or they are writing to the participant the intervention, so providing it through that means. So anything you would say in an in-person way, if it's Socratic questioning from a traditional cognitive restructuring point of view, you would write it instead of say it. You wouldn't have the benefit of the nonverbal communication that you can be able to cue in on as you are a therapist. So you lose that when you're writing it. But it was a way to deliver it and deliver it to people who could be very far away from the hospital. And this was provided throughout England. And so it allowed people who were not near the hospital to be able to get the treatment. And then the participant in turn could reply. They would write statements they were having and automatic thoughts they were having. They would write them to the therapist providing the treatment. So I think that's an interesting way in which they did it. You know, now we have Skype, and that could raise some interesting questions. And just like I'm giving this lecture via Skype, and I'm 1,200 miles away, it raises some interesting questions about how might that kind of technology be integrated. But they use text, and I think the other interesting thing about the study is that it worked. And I think that when they compared it to a usual care, which is certainly a stronger design than a waitlist control, and that I thought was a very notable control group, which allowed us to learn about how effective the treatment was. And so the other, I think, neat thing about the study was that it worked for severe depression. And again, when you're thinking about need, and who needs this the most, the people who are suffering the most are clearly benefiting the most, which is very, very interesting, because it makes me wonder, like, how did they manage to help people with severe depression and show that was more effective by using this online communication? You would think that maybe the people who had the least depression would benefit the most, because the intervention was less intense than a traditional in-person therapy. But compared to usual care, at least, the people with severe depression tended to do very well. Now, there's some problems with the study. The individuals in the study tended to be young and single, and they tended to be educated, and they tended to be women. And they had a fair amount of exclusion. So again, when you're thinking in terms of reach, they excluded people, for example, with a substance abuse problem or current alcohol use. They couldn't have had any recent episode of depression. So there's a lot of selection, a lot of exclusion, and that's going to limit reach. Nonetheless, this is a very valuable study, an important step, and as my colleague Yvette Ludman and Greg Simon at Group Health, just down the street from the Cancer Center, commented in their commentary on this article, they see this study as one of really a new direction that I think clinical psychology can be taking, of a very much higher reach, a much higher reach intervention, which they noted wasn't necessarily less costly. And I think that it would be valuable for Kessler and colleagues to calculate the cost effectiveness, and not less costly from Yvette Ludman's eyes, because simply these individuals were being provided therapy by a PhD level counselor. And so essentially for them is the same, because the amount of time it took to deliver the intervention was the same. But I think it'd still be useful to actually calculate cost effectiveness to see whether is this really, maybe it could be a little less expensive than providing individual therapy. And then there are a number of other studies that have been done recently on the internet, social anxiety treatments. And then my colleague Jennifer McClure at Group Health has done some interesting work on smoking cessation using the web, and combining that with pharmacotherapy, in particular providing it with bupropion. She combined it with Chantix, which is the newest pharmacotherapy for smoking cessation. And in other studies, she's done that with the patch, which is another nicotine replacement therapy. And then in the telephone modality, my colleague Yvette Ludman and Greg Simon have done interesting work on depression, using basically a hybrid model where they had people at the beginning provide group therapy sessions with a master's level counselor providing CBT treatment, what they call CBT light. They drew in some pieces of cognitive therapy. They actually did a little bit of diffusion. They pulled in a little bit of behavioral activation, and they put it together. So it was kind of a salad bar of treatments. But after they received this group therapy, their follow-up was by phone with the same counselor. So I was able to have some continuity in the therapy relationship and be able to use the phone really as relapse prevention, as a way to review skills that were learned in the group program and as a way to continue the therapy. So it was a hybrid model. And then a tremendous amount of work is being done in the last 15 years on telephone interventions for smoking cessation. If you dial 1-800-QUIT-NOW anywhere in the United States, or in the territories of the United States, you'll be connected to a Quitline program that is run by your state. So the state of Nevada has one, the state of Washington has one, and Free and Clear is a private company that is actually the largest provider of smoking cessation counseling in the world. They actually provide treatments. They've contracted with 17 states to be the Quitline program for those 17 states. And so they have bachelor's level counselors who are providing a cognitive behavior therapy counseling in a 5-session treatment by telephone. And counselors are standing by. You call 1-800-QUIT-NOW, and they are there about 20 hours of the day, 7 days a week, to provide therapy to thousands of people around the country to help them quit smoking. And they are providing, my colleague Tim McAfee are testing the effectiveness of their treatment. We have a grant in now with NIDA, and we'll find out in June if it's funded, to test ACT therapy versus the standard Free and Clear treatment program. So if you're interested in that, I can chat about that. Then my colleague Shuhong Zhu provides the California Smokers Helpline, and down at the University of California, San Diego, and he's published a number of articles looking at the effectiveness of his treatment program, which has some CBT elements and then some supportive therapy elements. So the public health approach, the key thing to see here is the modality is very, very different. They're using the phone, they're using the internet, and it's all in the service of trying to reach those traditionally left out by our usual way of helping clients, the face-to-face method. So I want to show you a way to study, to conceptualize the public health approach to providing interventions, to providing cognitive behavior therapies. And that is the RE-AIM model that was developed by Russell Glasgow. And I think the useful article, actually, and one I can send you, is in 2004 in the Annals of Behavioral Medicine, where he outlines what he calls the RE-AIM model. And the RE-AIM model is looking at what is the reach of your intervention, how effective is it. I've talked about those in detail. And then there are 3 other pieces that I haven't mentioned. And the first is adoption. So once you are providing your intervention, let's say it's through a Quitline or through a healthcare organization, through an HMO, or through a university clinic, or through some other program, you want to look at the rate of adoption of the intervention within that program. And so this kind of follows the Rogers diffusion of innovation theory model. He's a communications theorist, looking at how much is this new behavior, in this case the behavior is the therapy, being adopted by the organization that's providing it. And Quitlines and healthcare systems are examples of ways to anchor thinking about adoption. And adoption involves key things like training counselors, often counselors who don't have PhDs, who are master's or bachelor's level counselors. And also it's adoption at the level of the organization. To what extent is the organization bought into this new intervention? How much do they have faith in it? How much are they willing to devote resources to training people to do it and to keeping it there? Because you as the researcher might go in and show this treatment is effective in the healthcare organization. The really where the rubber hits the road is once you've shown it's effective, how do you get people to adopt it? And that's kind of the main point of Glasgow's writing and his work on this RE-AIM model, and that is there's a huge disparity between what we know is effective and what is actually getting adopted. And it gets at the issues of public health, because you may find something that works, but the challenge is how do you get people in healthcare systems and other systems to actually adopt it. And then when they're implementing it is to be able to implement the therapy in a way that they're implementing it correctly. That is, they're correcting it, they're doing it with fidelity. And so all the work and expertise we have in testing fidelity of our interventions can be very useful at this stage, because especially if you're going to have someone who has a master's or bachelor's level training, it's important to be able to see that they can be trained, and I do believe they can, and to show that they are able to deliver something with fidelity, and that's really critical. And then the last part of the re-aim is maintenance. Okay, so once they know how to do it and it's been adopted by the organization, you want to be able to come back 2 years later and show that they're still doing it with fidelity, that the program is still being used, that clients are receptive to it, and that there are still outcomes. So program evaluation research is useful there. Everything that we know about program evaluation research comes into play here, because you can continue to see and get metrics on how effective the program is. And this is also a place where you can do more cost effectiveness research to fine-tune the model within the healthcare system. And so re-aim is a framework. It's a framework you can use in research. It's a framework you can use in practice to understand how to provide an intervention at the public health level. The other thing that I think is worth mentioning about the re-aim model, and it is highly valued in this approach, and that is quality of life outcomes. In ACT therapy, we're beginning to bring in more and more measures of quality of life, which map on well to the focus in ACT on values. Well, the folks in public health research have been doing quality of life research for a long time, and they have developed solid measures, like there's the WHO measure, and there are other measures, the EuroQ, which was used, for example, in the Kessler study, are using well-validated measures of quality of life that we can use, or we can modify to fit the way we conceptualize quality of life. But they value the importance of not just symptom reduction, but also embracing that we're trying to improve the functioning of this individual, not so much the extent of meaning in life, but really the everyday functioning of the individual is typically how they think about quality of life. But I think the key thing to see is that they go beyond the traditional clinical point of view, which is symptom reduction, or a more medical model, which is symptom reduction. They embrace the importance of improving quality of life. And so they really are allies, and I think they really think more alike than it might seem at first. So I've talked about these dimensions, so I won't go over them because I've just mentioned them. The purpose is essentially reach effectiveness and show outcomes. I add show process leading to outcomes, because I think that's important as well. We need to know exactly how this is working, and are we targeting the process we want to see. Show adoption, show implementation, and then show that you can basically maintain through replication and long-lasting effects at reasonable cost. So, as I mentioned earlier, I like to show you an application of the re-aim model by giving you the example of ACT for smoking cessation. And I shared with you a recent paper that my colleagues and I have published in nicotine tobacco research using ACT for smoking cessation via telephone. The application that I'm going to focus largely on is in just helping you see that Quitlines have reach, and also to highlight some initial data we have on the feasibility and the potential effectiveness of the treatment. So we'll get into the RE part and not so much the AIM part of the re-aim model. So as I'm sure you well know, smoking is an enormous public health problem. About 20% of American adults smoke at least daily, and 27% of high school seniors smoke at least monthly. And unfortunately, these levels of smoking are far above the healthy 2010 guidelines, which are targeted for this year, and we're clearly not going to meet the target. 12% for adults and 16% for adolescents. And this is really sad. This is very sad and disappointing. The Surgeon General's report came out in 1964, and here we are 46 years later, we've made a lot of progress. We were about 40% in around 1963-64 was the smoking rate. So I think we're halfway there, but we have a long way to go. And let me tell you, the folks who are left are people with mental disorders, people who are poor, and certain minority groups. And so we have a challenge ahead of us. So while we have made progress, it's disappointing we haven't gotten down to zero yet. And this is just America. I haven't said anything about China. I haven't said anything about Eastern Europe, where the rates are getting closer to what they were where we were in 1964. And there are very few smoking cessation programs at the government level, and certainly at the clinical level in those parts of the world. So as you look ahead to the next 3 decades, China and Eastern Europe are really going to be very serious problems where we're going to see very serious levels of lung cancer, and it's going to take a while for them to really begin to implement programs culturally appropriate to help those countries. So we have a challenge in the United States, and we have an even bigger challenge in another part of the world, particularly China and Eastern Europe. In the United States, this is the leading cause of preventable death, and it kills about 400,000 people annually. Illness is attributable to smoking. So we are working to address this need. Particularly Quitlines are a really important part of the overall tobacco control infrastructure. Quitlines are funded by 3 sources. They're funded partly by the U.S. government, mostly by each state. So each state will devote a part of their annual budgets to funding Quitlines. And then in third, they're funded privately, but mostly by insurance carriers. So for example, people who work at Microsoft here in Redmond, Washington, all of the healthcare plans at Microsoft, the contract they've negotiated, those healthcare plans will provide free Quitline counseling to anyone who's an employee who wants it. Now, I should also say, if you don't have insurance in the state of Washington, you can get free Quitline counseling and nicotine replacement therapy. And so Quitlines are doing a lot to reach those in need. And they're also reaching those who are not necessarily not able to afford it, but to be able to get it covered through their insurance. Quitlines are addressing the barrier to reach. Quitlines are accessible. 95% of people have a telephone, and 85% of people have have cell phones. So this allows the folks who are rural and suburban areas to have access. As I mentioned earlier, it's available in all 50 states. It's covered by insurance or Medicaid, I should say, it's the main federal source of funding, or by the state. And it costs substantially less. So at the cost to the Quitline to provide a therapy, a 5-session therapy plus the nicotine replacement therapy, it's about $350. And in contrast, if you did a 5-session face-to-face therapy, you're getting up close to $1,200, $1,500. So it was a huge cost savings. But on the other side, they're only about 17% lower fraction. So it's 83% as effective as a face-to-face therapy. And that may seem surprising, but in the case of smoking, it's true. They're getting not that much lower quit rate. So if you're looking at the cost effectiveness, you see it's pretty clear. It's a pretty cost-effective therapy, $350 versus around $1,200 to $1,500, and it's only 17% less effective. It's relatively brief. Usually a typical session, so for example, Free and Clear, their first session is 30 minutes, and subsequent sessions are 15 minutes. So you get 30, and then you get basically an hour after that, 4 15-minute sessions. And many demographic groups make use of them. Everybody who had been left out of traditional therapies are in the telephone therapy. So Quitlines serve a substantial number of men, minorities, and the poor. So let me show you an example of the first Quitline study I did with my colleagues. I call it the ACT Now study, for looking simply about whether we could provide ACT feasibly by phone. This is my simple way of just presenting the conceptualization of ACT. I mean, you're all extremely familiar and trained and versed in ACT. What I show to clients and to study participants is a metaphor that's like this. Essentially, you're moving in a valued direction. There's something at stake here. There's something really deeply important to you about the whole process of quitting. So you're taking action in a valued direction. So the act of talking on the phone, the act of reducing your smoking, allowing yourself to have sensations, those are all in a valued direction. So it might be to make sure you have the health to see your grandchildren grow up. You're moving in a valued direction and you're making room. You're making room for your baggage, and that might be urges, it might be self-judgments about quitting, it might be feeling sad, it might be feeling anxious, and so you're learning ways to make room. This actually comes from a milk commercial in the Netherlands, and I just think it's cool, so I like it to show a way to think about ACT. Now, in the actual intervention I use, I have a person driving a car, and then there's a counselor sitting next to them in the front seat. So they're like a front seat driver helping them navigate, and the back seat, like baggage, or their urges, their triggers to smoke. This is the same idea. So ACT has promise for smoking cessation. To date, there are 4 studies that have been done with ACT for smoking cessation. The first compared ACT with nicotine replacement therapy. This was Liz Gifford's doctoral dissertation. And she showed a 21% versus 9% biochemically verified 24-hour abstinence at 12 months follow-up. There are various measures of abstinence we use in smoking cessation research, and I'd be happy to tell you about them. We like to biochemically validate the measures of smoking cessation. So I certainly trust my study participants, but my peers who review scientific articles don't necessarily, and so they like to see some kind of biochemical validation to see that people are truthful about not having smoked, or if they might have forgotten. And that showed great promise. And then actually Liz also did a second study where she combined ACT with FAP. And she basically, in the way I think about it, she turbocharged ACT. She put the therapy relationship as kind of a foundation on which the ACT therapy rested. Now, of course, if you do ACT well, ACT and FAP are, it's very similar, but she was very intentional about bringing in FAP elements, worked closely with Barbara Kohlenberg on doing that. And they compared that to Zyban, which at the time, which was around the early mid-90s, that was the kind of the hot pharmacotherapy to provide, just like varenicline and Chantix is now. It turns out that Zyban, which is also an antidepressant, also known as Wellbutrin, is not that effective of a smoking cessation treatment, though in her study, still 20% of people quit, and all they had was the Zyban. And in the ACT and FAP group, it was 35%. That's very impressive. And that showed a 30-day abstinence at 12-month follow-up. So again, we're getting very encouraging data. And then I worked with Monica Hernandez Lopez on a study that was done in Almeria, Spain, several years ago, where we did a quasi-experimental study. So they couldn't be randomized for reasons I can talk about if you're interested, where they got ACT therapy with no pharmacotherapy versus CBT, which was the therapy that is the standard of care, delivered by the Spanish Association Against Cancer. So one of the neat things about Spain is in actually different regions of Spain, there is a center you can go to that provides preventive care to prevent cancer, such as smoking cessation, weight loss, and diabetes management, or a resource center for helping to cope with cancer. That's not something we have really built very much here in the United States. That's not really an infrastructure we have. Although one exception is the Hutchinson Center does have the Live Strong Foundation. We have a small center here which provides weekly, it's basically psychoeducation and some behavioral treatments for cancer prevention. But typically that's not something you'd see in most places. So the therapist there at the Spanish Association Against Cancer, he provided the CBT treatment in a group format. And it was a dissertation, so it was a modest-sized study. It was 81 people, approximately equal, approximately 40 per group. And very impressive and promising quit rates, 30% in 12 months versus 13% in the CBT control group. And that was also actually biochemically verified. That they used carbon monoxide. You blow into a device, and it basically tells you the levels of carbon monoxide. So that's very promising data. And then Richard Brown at Brown University has been doing work on ACT with some exposure variations and some other variations which have kind of drawn actually from the world of treatments, exposure-based treatments for OCD, to compare that with CBT for smokers who haven't quit for at least 3 days in the past 10 years. These are what he calls the early smoking relapsers. So he was very interested in a very special group of smokers, and he felt that what he calls distress tolerance. So you'll see he has a somewhat different way of thinking about ACT than we might, but I think the essence is still there. But he calls it distress tolerance. And he's showing some promising quit rates in that. That was presented at SRNT Dublin last year. If you're not sure what SRNT is, that's Society for Research on Nicotine and Tobacco. That's the main research outlet for smoking cessation research. And that was 19% versus 9%. So the thing is, in all 4 of these studies, they're all face-to-face. They're all group therapy or they're group plus individual. And so what I did was I took a synthesis of the Gifford protocol and the Hernandez-Lopez protocol, and then my own ideas about ACT, and then we developed a 5-session ACT therapy, smoking cessation intervention. And I made it the same length as the standard of care at Free and Clear. So that way, if we ever were to test them, compare them, which is the hope, we would be able to make a stronger inference about the comparison because they've been matched on dosage. So you get 30 minutes for the first call, and then you have 15 minutes for subsequent calls. And the total length is up to 90 minutes. I pilot tested this in spring of 2008 with 14 adult daily smokers. And we were trying to learn also if we could get some real-time surveys, do some type of ecological momentary assessment of their urges to smoke and to learn how they're responding to them in the moment. So we did that at baseline and post-treatment. And then to learn about how the feasibility, how much, whether we could actually deliver the intervention and were participants receptive. Was there any evidence of change in ACT processes, and was there any evidence of change in smoking behavior? Sample was 40% female. I made a point of including minorities. I actually recruited through the Dallas, Texas area because that has a higher population of minorities with a high smoking rate. And we had 8 minorities, and they were all were African American. The median age was 49, and as you see, the 64% met the definition of the federal guidelines for poverty. They screen, 40% screened for depression. That's using the Murray Stein and Peter Royburn's and Alex Bystrisky's measure called the Anxiety and Depression Detector. It's a 4-item scale. It measures a detection for depression and detection for anxiety, which has very good. It has very good sensitivity. It's not. Doesn't have the highest levels of specificity that they would like, but it's an indicator. So I call it a screen. And 64% smoked at least 10 cigarettes a day, at least half a pack. So we found first that we can deliver it by phone. The mean contact time was 82 minutes. On average, people had 3.5 calls, and 33% had all 5 calls. People were very highly receptive. I used Scott Miller's measure as a brief measure of receptivity to therapy, and so it showed that They felt respected by the counselor. Majority felt it was a good fit for them, and 86% thought the intervention was helpful to them. These are measures taken at the end of treatment. In terms of ACT process, I think that this is a very important way to learn whether we're moving anything. Are we moving the process that can predict smoking? In our real-time assessment, we found that it increases in the willingness to experience physical cravings, emotions, and thoughts that cue smoking. So it's an adaptation of the Gifford scale of avoidance and inflexibility, which is an AAQ specific to smoking. And then the commitment to quitting. And this is using Chris Kaler's scale developed. He's a collaborator of Rick Brown, looking at commitment to quitting, and that increased as well. At 20 days post-treatment, we had very promising quit rates. 24-hour point prevalence, that means haven't smoked in the last 24 hours when the time you took the survey, of 43%. 29% 7-day point prevalence, and 24% had made it, 71% had made a quit attempt in the last 24 hours. Actually, since the beginning of the study, they had made a quit attempt for at least 24 hours. And so a majority of people had at least made an attempt. And then the reduction from daily to less than daily, 62% of individuals from baseline to post-treatment. And then we did a follow-up last summer where we had very high retention. We maintained a good rapport with our participants, and so my team of telephone trackers were really good at being able to survey them. And the prolonged abstinence, which means that they haven't smoked at all in the last 12 months, was 29% using an intent to treat analysis. And then if we just used the complete data, that is the people for which we had data, the rate was slightly larger. It was 31%. And nobody relapsed of any of the study participants. And I think this is promising because this rate is over double the 12% quit rate of adult quitline counseling using the Mike Fiore meta-analyses in the PHS guidelines. So this is very promising. And the other thing I think is interesting is that the quit rate is similar to all the prior face-to-face ACT smoking cessation studies of 30 to 35%. So here we are. We're going from an individual therapy with group and with individual therapy face-to-face, and we're getting a fairly similar quit rate. Now, bear in mind, this is only a feasibility study, and so we want to learn how well it works actually in a randomized trial. They were obtained with people with a high fraction of depression and a high fraction of minority sample, and they typically have low cessation rates. The process results certainly comport with the ACT model, and I think the interesting thing is this is actually the first time that ACT has been documented in a research study as being done by telephone for any kind of problem, depression, anxiety of any kind. We just happen to use it with smoking. So in summary, I think that the public health approach provides a very promising direction for increasing the reach of our CBTs. And I think the telephone is an example of a public health approach that provides a personal intervention that has wide reach. And I think that the quit rates can be improved in the future with ACT therapy. And we will find out once we conduct the trial. Thank you so much.